Sun. Professor Sun is a distinguished ophthalmologist and professor at Changgung Memorial Hospital in Keelung, Taiwan. He graduated from Kaohsiung Medical University in 1994 and earned his doctorate in clinical medical sciences from Changgung University in 2006. Dr. Sun completed his ophthalmology residency and a fellowship in cornea, external eye, and refractive surgery at Changgung Memorial Hospital. He has published over 150 peer-reviewed publications in the fields of stem cells, ocular surface diseases, keratoplasty, refractive surgery, and dry eye disease. Dr. Sun has held leadership roles, including former director of the Department of Ophthalmology at Changgung Memorial Hospital, and he currently serves as president of the Taiwan Society of Cataract and Refractive Surgeons. Please give us a warm welcome for Professor Chi-Chin Sun.
Thank you, Anton, for the kind introduction. I'm Chi-Chin Sun from Taiwan. I'm currently the president of Taiwan Society of Cataract and Refractive Surgeon. The topic today for my presentation is ocular surface consideration in cataract surgeries. I did receive an honorarium from AIOS. However, the presentation of my slide just reflect my own opinion, not relevant to AIOS company. Talking about ocular surface in dry eye disease, we have to know about the global trend and risk of dry eye disease worldwide. As you know, the global prevalence of dry eye disease is increasing. Some risk factor identified just like the Asian ethnicity, greater age, and female sex are also identified. According to my own study, we published in American Journal of Ophthalmology, we found that overall prevalence of dry eye disease is 7.85%, and increasing with more predominant incidence in women population. Why is managing dry eye disease critical in cataract surgery? As everyone knows, that cataract surgery is the only preventable disease to prevent blindness in the elder population in many areas of the world. However, an impaired ocular surface poses significant challenge when we plan for cataract surgery. Vice versa, cataract surgery alone can also exacerbate the dry eye disease. Therefore, a consensus of managing dry eye disease before, during, or after cataract surgery is essential. How does dry eye disease affect the cataract surgery? As mentioned, it poses challenges preoperatively, especially in accurate preoperative evaluation, including accurate IOL power calculation and estimation of the astigmatic axis and the degree is important. However, dry eye disease can also obscure intraoperative surgical field, interrupt the wound healing, and most importantly may disrupt or compromise the patient satisfaction after cataract surgery. So how does tear film stability impact on keratometry? There are accumulating evidence demonstrated that keratometry measurement may be inaccurate, greater than 0.5 diopter. Also, irregular corneal topography pattern may appear, and especially when we treat the patient beforehand, we can lower the refractive surprise in the pretreatment group. This is another study also pointing out that when we pretreated dry eye patient before cataract surgery, the mean absolute error was significant decrease from 0.42 to 0.23 diopter after surgery. Also, the number of refractive surprise was significantly lower in the pretreatment group. Let me show you a case. This is the 76-year-old gentleman who came for cataract surgery. He has the meibomian disease and a dry eye disease. And he asked for a premium lens explantation, to correct the astigmatism and also presbyopia. However, when you check the preoperative autorefractometry, you can find a significant discrepancy between the autorefraction and keratometry. So astigmatism major correlate poor with the refraction. To validate if it is right, we perform a series of examination, including the op-scan, the contact biometry, and again we found a discrepancy between these measurements. So the biometry obtained by Master 500. So in this case, should you proceed with a toric IOL? I think the answer is definitely not. Therefore, we performed the surgery on this patient with just a single monofocal lens. However, post-op day one, the visual acuity was just 0.1. Certainly, she was not happy. But don't forget a dry eye, because the dry eye disease can, compromise the patient's satisfaction after surgery. Therefore, we adopt aggressive treatment, including topical steroid, preservative artificial tears, tetracycline to treat meibomian gland disease, and lubricant eye gel. And when he came back 1 month later, visual acuity improved to 0.7, but he was still not unhappy and complained. 2 years later, you see the reflection here is quite good, and with glasses, patient's vision can improve to 0.9. But continuing medication treating the underlying dry disease was prescribed. So you can see the importance of the dry treatment for the patient's satisfaction after the cataract surgery is very important. Second, we should know the patient's ocular surface disease is important before surgery. So how do we diagnose the patient with dry and how we classify? I think DUSE 2 has provided us a very good example. As you know, that DUSE 3 will come in a couple of months, but by the definition of DUSE 2, it's defined the loss of tear film homeostasis plus ocular symptoms. So with underlying pathophysiology like the tear film stability, hyperosmolarity, ocular surface inflammation damage, plus neurosensory abnormality. So we can classify dry disease into aqueous deficiency, evaporative, or mixed type. So in short summary, we screen the patient about their symptom with the many questionnaire like OSDI or DEQ5, and plus some homeostatic marker like non-invasive or invasive tear film marker. So far, I don't think that tear film osmolarity is quite popular among the many clinicians because of the a little bit, not inconsistent with the clinical diagnosis, but fluctuation is quite correlated well with the severity of the symptom. Therefore, last year in Taiwan, under our endorsement of TSCS, we published a dry eye disease consensus report. This report not only point out general guideline to general dry eye patient, but also emphasizes on the perioperative measurement of dry disease after cataract surgery. If you are interested, you can scan the QR code and refer to the paper for detail. According to our definition, dry eye is a composite disease of ocular surface and developed from the stability of the tear film, where local inflammatory processes may result in manifestation of ocular symptoms that contribute to ocular surface damage. Why local inflammation are important in dry eye disease? This is the paper published in 2009 by Lam. He pointed out that the difference between patients without dry eye disease and dry eye disease is significant difference in many cytokines like the interleukin-13, interferon gamma, AIOS6, or TNF-alpha. So it's important in terms of dry eye disease, the local inflammatory process. And what is the Taiwan-specific algorithm for dry eye disease? Not so much different, but we emphasize on, plus the, aside from subjective questionnaire, we adopt tear breakup time, either non-invasive or invasive tear breakup time, plus corneal fluorescein in staging the label of the dry eye disease according to the corneal fluorescein staining. And we also subtyped this dry into evaporative, aqueous deficiency, or mixed type. And a four-step treatment for each severity is recommended. So we have to know that what's the prevalence and risk factor following dry eye disease. As you may, it's published in the literature, the prevalence of post-cataract surgery dry eye disease vary from 9.8% to 55.7%. The incidence from non-dry eye disease to dry eye after surgery may increase up to 31.3%. But we have to know that most of the patients have subtle of dry eye change but not identified yet. So it's very important to identify beforehand before this patient are planning for cataract surgery. This is a paper published last year in American Journal of Ophthalmology from our group. The aim of the study was to examine the initial presentation related to sex and identify risk factor of this concordance between symptom and sign of dry disease in Taiwan. Over 1,000 patients that was included, analyzed, we found several strong predictors of the incongruity between dry symptom and the sign. That include age, gender, surgical history of cataract, pterygium, or conjunctival chalasis, and artificial tear use. Our suggestion is that ophthalmologists should prioritize symptom for female patients and those with a history of post-cataract surgery dry cases. We also, 3 years ago, published on American Journal of Ophthalmology to identify risk factor for ocular surface damage in aqueous deficiency dry eye disease. Why is it important? The patient are dry and risk for corneal surface disease, these are the highest risk for developing dry eye after cataract surgery. In our study, we found that diabetes, rheumatoid arthritis, and systemic lupus erythematosus was positively associated with systemic steroid was negatively associated with ocular surface damage in dry eye disease. This is why we found diabetes and some autoimmune disease. So talking about the pathophysiology mechanism, how cataract surgery affecting ocular surface, I think everyone will acknowledge the nerve transition, the different corneal nerve entrance during cataract surgery is important. So there's some doctors advocate use the superior corneal to avoid the truncation of the nerve. Other risk factors like the intraoperative lightening or preoperative use of topical anesthetics, and also the elevation of inflammatory cytokine, or with the increasing use of reflex surgery, some demonstrated damage within the flex. All very important. I think later on, Dr. Gita will give us a brief introduction of the if very dry, the meibomian dysfunction, its impact on the post-cataract surgery dry disease. It's very interesting. Our group also found that in patients with diabetes, dry eye is also very run a risk for post-operative dry eye disease. What we found is that dry eye in diabetic patients with who were female sex and advanced age or poor glycemic control or microvascular complication like diabetic retinopathy or neuropathy, and those receiving ocular procedure like the intravenous injection or cataract surgery or transplantar vitrectomy, all at risk for developing dry eye disease after surgery. But very interestingly, we found some anti-glycemic medication like GLP-1 or agonist or SGLT2 antagonist, DPP-4, and insulin are superior to metformin alone in preventing DM-related dry eye disease. So it's here you can see the association between the cataract surgery or other intraoperative procedure that induce the dry in this specific cohort, I mean the DM patients. So let's we move to the treatment of dry disease after cataract surgery. What are the main needs exist in dry treatment guideline? According to these two, it identified gaps in like in head-to-head comparison study about different artificial tears, leading to non-conclusive guideline for artificial tears use in dry patient. Therefore, our study published another paper. We evaluated two artificial tears that containing hyaluronic acid in the post-cataract surgery dry eye disease. We recruited 70 patients and allocated this patient to two groups, HB-GUA HA group and CMC group, another brand name which contains the hyaluronic acid. Here is the study protocol. We evaluate and recruit a patient who developed dry 1 week after surgery. Aside from steroid and antibiotics, we just use a sustained hydration up diffusion and then come back for 1 week and 3 weeks later. The primary endpoint was corneal fluorescein staining compared to baseline. others secondary endpoint like OCI, Schirmer's test, tear gap time, and corneal sensitivity was also assessed as well. Below are inclusion and exclusion criteria. So what we found that all the secondary parameters, they are all not significant. However, it's very interesting to find that HA group was superior to CMC HA in improving corneal fluorescence staining as early as 1 week after surgery. So it means that it shows superiority over CMC HA artificial tears. Why is that? We think possibly related to the variation in HA concentration, molecular weight, and additional polymer, because we know that the molecular weight of HB-HA in this study is high as 1,300 kilodalton, which is favorable in treating ocular surface damage. Additionally, the pH-D sensitive nature of FGV-GuAR leads to an increase in the viscosity on the ocular surface when they are exposed to ocular surface. So what Taiwan dry consensus report suggests? Our study, our guideline suggests a more aggressive treatment of strategy because to treat this patient to optimize their surgical outcome. So we have a specific post-surgical follow-up, which is recommended. I will give a short brief introduction. Most importantly, we should prioritize those patients who were at low, moderate, or high risk of dry eye disease, which were relevant to postoperative dry eye disease. So preoperative, we should aware of the patients about the possibility of worsening dry eye after cataract surgery. It's very to pay attention to those who have asymptomatic incidence of dry eye disease because they may develop dry eye after cataract surgery. Specific consideration intraoperatively, we should adopt to avoid all these factors that contribute to postoperative dry eye disease, and preoperative treatment should be aggressive. If the patient have the dry eye before cataract surgery, we should aggressive to treat this patient and downgrade their severity, so as to to proceed to the measurement of the ocular surface, some parameter keratometry, topography, etc., and to improve the accuracy of your measurement. And then we have to stratify this patient, as mentioned, as to if they were at risk for dry eye disease after surgery. So it's very simple, not different, but we adopt a very aggressive treatment because the patients, because of the corneal fluorescence thing, we interfere with the accuracy of the measurement. So we have to downgrade. If there are 3 or level 4, you have downgrade at least to 1 or 2, and then proceed to the refractive measurement, and then finally to go for cataract surgery. So this is a specific follow-up regimen. For this patient that possibly developed dry eye disease, early as 1 week or 2 weeks after cataract surgery, we have to check the tear gap time corneal fluorescence staining to evaluate if they develop dry eye disease after surgery. And also we have to adopt, as I mentioned, more aggressive treatment, starting at more advanced level. It's offered at 3 steps. First step, to inform the patient. Some patients, they are afraid of using the eyelid hygiene, so it's very important to use the wipes to clean up the excessive oil to avoid the contamination of their eyelid or either develop infectious keratitis. Step B or C, which is indicate for patient with corneal lesion. In this patient, preservative-free artificial tears, Panta plug, or cyclosporine or steroid should be used. For more advanced disease, we should use the autologous serum for this patient. So the key takeaway here, dry post-change before, during, after cataract surgery, it will interrupt with the measurement accuracy and also dissatisfaction with the visual outcome. So screen diagnosis before cataract surgery is very important. And then we have to pick up or to certify this patient who are at high risk for dry eye disease. For example, autoimmune disease, type 2 DM, or post-refractive surgery cases. And finally, we should adopt a treatment strategy, aggressive treatment strategy for those patients who develop dry eye disease after cataract surgery. With that, I conclude my talk, and on behalf of the Taiwan Society of Cataract Refractive Surgeons, I welcome all of you to attend our annual meeting in conjunction with the Third Global Young Ophthalmology Summit, which will be held in Taoyuan, Taiwan, very vibrant city of Taiwan. Thank you so much. Thank you.